All right, good afternoon. Thank you very much for the opportunity to present some of our work here regarding a case study on a pilot project that we did on utilizing telementoring in front of a live audience. My name is Dan Hashimoto, and I'm a general surgery resident at the Massachusetts General Hospital. We have no relevant financial conflict of interests. Telementoring and telemedicine has really been picking up in terms of mentions and increased curiosity both in the lay press and academic literature as well. Telemedicine has really been picking up in steam, really even within our own health system. I can tell you there have been initiatives to incorporate telemedicine into patient care, particularly as it relates to primary care clinics and wound care clinics. Telementoring, however, is a little bit different than what you would think about in the medical specialties. Telementoring is really defined as being that in which there's remote, real-time guidance or technical assistance that's occurring from an experienced surgeon to another, and that surgeon is likely in a different location, and they're using audio-visual communication techniques. Studies that have been done in the past, going back even 20 years, have demonstrated that there's very little to no difference in knowledge acquisition that occurs between traditional mentoring, live mentoring within the operating room, and telementoring. And that's actually a good finding, because a lot of times there can be situations where you need access to mentorship, either in a remote area or in a just-in-time situation where it may not be cost-effective to have somebody come in from the outside. SAGES in particular has been particularly interested in looking at telementoring. In 2015, a summit was convened called Project 6. And that gathered together various stakeholders from within SAGES and industry and other groups. And that sat down and really tried to define a framework under which telementoring could be safely performed. Now, granted, that was quite an exhaustive kind of discussion, but three main takeaways that occurred from that is that really to have an effective and safe telementoring relationship, the mentor and the mentee have to have some sort of pre-existing relationship with each other. And this is really key to understand what's the level of trust that's going to occur between the two parties. The mentee has to be competent to manage that disease or perform that operation without the need for a mentor. And this is absolutely crucial when you think about connectivity from current devices. There's times when that device can go out, and so you want to make sure that the patient's safety is not compromised and that that person is competent to continue carrying on with that operation. So really that lends itself really well to thinking about situations where a surgeon may be wanting to try a new technique out, or maybe is looking to use a new instrument, but can readily fall back on their usual technique or instrumentation. And finally, it's key to have an educational framework established where both the mentor and the mentee have kind of pre-existing and predefined goals for their educational interaction that's going to occur through telementoring. When we think about the various telementoring platforms, you can start kind of at the quote-unquote lowest rung. When you think about the consumer platforms that anybody can kind of buy off the internet or Best Buy. Probably one of the most famous attempts at doing this was the infamous Google Glass there on the left. And then more recent types of technology are the Microsoft HoloLens, which is more of an augmented reality platform that you see there on the right. There are, of course, specifically designed instruments for telemedicine and telementoring, and that can include specific things designed for healthcare settings. And then there are hybrid platforms that are currently under development at various academic institutions. This is an example from a lab at Purdue where they actually combined Microsoft HoloLens with specific surgical software to really try to augment the telementoring experience and educational benefit. What we sought to do was take advantage of the fact that SAGES was in Boston last year. And so we really wanted to see if we could use the Project 6 Telementoring Initiative framework to assess the safety of telementoring in a live audience. So we established a live link between the operating rooms at the Massachusetts General Hospital and the SAGES 2016 Exhibition Center. 2 operations were performed over the course of 2 days, and attendees at SAGES were invited to come watch from the exhibition center. Critical to this was there was a third surgeon involved, and that surgeon acted as a commentator, available to explain technology, the case, and the principles of safe telementoring to the audience. For the clinical setting, 2 patients consented to having their operations done under telementoring, and 2 surgeons participated. Now, these 2 surgeons did have a pre-existing relationship in that they were partners in a surgical practice. Both are bariatric surgeons who perform sleeve gastrectomy quite frequently in their practices. But they do use 2 different techniques. So in the setup for this particular particular project was that they were going to try each other's techniques and see how that went. They had, of course, agreed in advance to being involved in this type of telementoring relationship. And from a regulatory perspective, it made it easy that both physicians were licensed in the state of Massachusetts and both were credentialed within the same hospital to perform sleeve gastrectomy. With regards to technology, we did use a commercially available surgical telementoring device. It had some remote pan and tilt capabilities so that the mentor could control the view, built-in laser pointer telestration, and then integration of camera view from the room as well as from the laparoscope and the endoscope. We did separate out a separate Ethernet connection from the hospital to the exhibition center, and we had pretty good bandwidth with low latency. This gives an example of kind of the preoperative setup where the machine was rolled off to the side to not interfere with the care that was being provided for by the nursing team and the anesthesiology team. This is just a quick view here of, on the right, you see a view from the laparoscope, and this is the view that the mentor is getting. And then on the left, you can see that the robot is able to look directly at the operating surgeon to provide at least some sort of presence there with the mentee. Very briefly, I want to show you a quick video where now you've seen that the device is actually now positioned immediately adjacent to the mentee surgeon, again, to try to recreate this sense of presence. And you will hear the mentor, or the woman surgeon, speaking back and forth, basically as if they're carrying on a conversation within the operating room.
Find that you need your assistant to do this.
No, actually, I was thinking about this right now a second ago. I was actually really pleased that Elaine is helping doing this part. Normally, I do by myself. Denise, you agree with this line right here?
Yep.
Okay.
And so not pictured here is that the telestration capabilities allowed them to really communicate where exactly they were particularly thinking about coming across with their stapler and things like that. Let's see if I can get this to continue here. There we go. So ultimately, we had pretty good data transmission between the two centers. We had less than 3% data packet loss. When we conducted a debrief and focus group after the telementoring experiences, both felt quite comfortable doing this in front of a live audience. And what both mentioned were key was that there was that third-party surgeon there. So they tried to minimize the distraction element of the audience engaging with the mentor so that the mentor could focus specifically on the mentee to ensure that the operation was proceeding smoothly. That being said, within technology itself does have some issues or limitations, and that the surgeon felt that perhaps there's too much navigation involved with driving the actual mentor console, and that might have been distracting. Of course, there are limitations. This is a case study, effectively, and so generalizing off of this would be fraught with danger. But it does kind of establish that it is possible to use telementoring within a live audience type setting. Both surgeons practice at the same institution within the same practice, so setting up that relationship was quite easy. But it begs the question as to how would this occur if there were different institutions or across state lines. And our network connection was great. We're within the same city, but it remains to be seen if there was some distance, how that would hold up. The next steps are that obviously further work needs to be done. Controlled studies need to be done to really assess the objective metrics of learning and safety in using telementoring. And then based off of data collected from this, and I know SAGES is currently engaged in some work on trying to really drill down on some of these aspects, it's really engaged for advocacy on clear regulatory and legal guidance on licensing and credentialing for surgical telementoring. Because you can imagine that can be potentially fraught with some issues, legal issues, crossing state lines and whatnot based on the current practices for licensing and credentialing. But ultimately, we did conclude that this Project 6 framework that was established by the SAGES Telementoring Committee can be used safely in a live audience setting. Thank you very much.